those of you who are joining us for the first time, thank you. And thank you for your patience. Something very interesting happened here this evening that I think is God's way of giving us an opportunity to properly introduce the topic tonight, the use of technology, and how important it is for us to commit and to believe. For those of you joining for the first time, I'm Selwyn Collins, your host. And CWS is about having conversations with people about their journey, how they're using their gifts and talents to help others, and to make a positive contribution to humanity. As such, I'm always looking for people who are doing extraordinary things or doing things extraordinarily well. And one of the things I always advise is the importance of giving beyond ourselves, the importance of giving without expectations. And so I usually ask people, imagine sharing your story with the world or sharing your story with a group of people. And there's a young person who is able to step beyond their limitations and step beyond their challenges because they heard how you overcame some of your challenges. And just imagine that same young person one day becoming a famous cardiologist. This is not a plug. I am saying this, it's just interesting that Dr. Ernest Madu is a famous cardiologist tonight. But the point I am making is imagine that young person becoming someone very special. Someone who may invent a vaccine to save millions of lives, a head of state, someone who stops a genocide. We do not know. And this is why I encourage us to share our stories, because to me, when we meet, when we share, this is how we're best connected as human beings. Tonight there is a technology glitch, and because of perseverance, we are here tonight to share with you this gentleman, this doctor, this innovator, Dr. Ernest Madu. I'm not going to take a break. I'm just going to bring him on split screen. Dr. Madu.
Hello, Selwyn. Thanks for having me.
Good evening. Good evening to you.
Good evening.
My brother, you know, the first time I saw you was on TED.
Yes.
I was just browsing, looking for things, and things on Africa. And
Right.
I had just heard a speech by this guy, Nadu, talking about Africa as an important place for development and investment. And then I came on your speech. And there's only one thing I must say to you. I was left hanging when you ended, only because I wanted to hear more. I mean, affordable healthcare for poor communities, brother, and you have
Yes.
championed this cause for so long. No, we have to share this with as many people as possible. So, congratulations on all your accomplishments.
Oh, thank you, and thanks for having me.
Oh, you are quite welcome. I am, since we've lost time, I'm just going to read a few snippets of who you are, and then we'll get straight into it.
Okay.
Founder and CEO, Founders Center of Excellence for Cardiovascular Disease Treatment in the English-speaking Caribbean. Dr. Madu is an internationally recognized cardiologist and an accomplished clinical investigator whose research works have been presented internationally, published, and cited in leading journals of cardiovascular medicine, including the Journal of the American College of Cardiology, Circulation and Nature. He is a fellow of the American College of Cardiology, American College of Physicians, and the American College of Chest Physicians. Dr. Madu is one of a handful of non-European cardiologists to be recognized with the award of Fellow of the European Society of Cardiology College. He serves as a reviewer for several leading cardiology journals, including the journals Echocardiography, Journal of the American Society of Echocardiography, Circulation, Chest, and the American Journal of Cardiology. He has served as member of the International Committee of the American Heart Association and on the board of the Association of Black Cardiologists. He has also previously served on the clinical faculty of the University of Florida and UCLA, both in the US. A successful healthcare entrepreneur, Dr. Madu serves on the boards of International Healthcare Services Limited, Medical Imaging and Diagnostic Inc., and Echo Doctors of America, LLC. Dr. Madu, lecturing, teaching, saving lives through innovation, and reducing costs in your endeavor to provide affordable health care to poor communities are truly beyond words. Did you ever imagine that your career, your life would have turned out this way, that you would be so dedicated to such a cause?
Very interesting. The honest answer will be no. Yeah, you never know how your life will turn out, but you do know what you believe in. You believe in making a difference. You believe in solving problems. You believe in equity. You believe in fairness. You believe in redressing wrongs where you see them. Now, you will never be sure how exactly you are going to redress those wrongs. But as long as you believe and you have the courage to pursue your dreams, and you are passionate about what you do, ultimately you will find an anchor, you'll find a channel towards where you can express all of these virtues. Just reminds me of a quote I heard recently from Maya Angelou. Talks about courage being the most significant of virtues, because without courage, it's impossible to practice the other virtues. So the most important thing for me is having the courage, to drive my passion, to make a difference in the world. And hopefully, with the support of many others along the way, we believe that we're making some little contribution to the global community.
Wonderful. I'm interested in exploring the genesis of such an amazing human being. So, can you tell us where exactly you were born, and what do you remember about growing up as a 9-year-old and then as a 15-year-old?
I was born in Nigeria. I was born on the eastern part of Nigeria. When in my days as a 9-year-old, didn't have very good memories to remember. If for those who follow the history of Nigeria and West Africa, you might be familiar with the worst, probably the most horrific crimes against humanity committed against the eastern part of Nigeria, resulting in a 30-month civil war. Biafra was an enclave that succeeded out of Nigeria at the time because of the genocide committed against the Easterners. I was young at the time. That's the memory of my 9-year-old person. We were running from place to place because of bombardments. Area bombardments, lost a lot of my very close friends who were killed because of the bombings. And so those images persisted. And I think that's where the roots were sown. Seeing a lot of suffering and carnage during that war, seeing a lot of helplessness and hopelessness, and seeing that, adults that could be the ones that saving lives were actually the ones that were costing lives.
Dr. Madu, hold on a second. Can I just interrupt you for 1 second? Could you move back a little bit from the camera? We're not seeing like the bottom of your mouth. Yeah, not so far, but yes, that's good. That's good. That's
okay.
Good. Sorry about that.
Yes. So those were the memories. At age 9, I was 7 years old when the war started. The war lasted for 3 years. I was 10 when the war ended. So my memory between the ages of actually from 6 to 10 were memories that were clouded by a lot of carnage and devastation and helplessness and hopelessness occasioned by the war that was brought upon us. Now, seeing those events unfold during the war, seeing the amount of damage and devastation and disease and death occurring at such a young age, it was quite an impression that was made on my very young mind. And at that point, it was very clear to me that whatever I did, I had to be part of the solution, not the problem.
Wonderful. Can you give us a glimpse of your teenage years in school? And what it was like for you? What did you like to read, and what were your favorite subjects?
Well, interesting. Now going back to the 15-year-old, it was a very joyful time. We were out of the war. I was going to a boarding school. Had a very fantastic experience going to that boarding school, College of the Immaculate Conception in Nigeria. We had very great teachers and mentors, and we had very strong team of young people who were very competitive and committed. At the time, fortunately for me, I was very well rounded in the subjects. I was as good in arts as I was in science and mathematics. I did pure maths, I did mathematics, I did English and literature. My best subject at the time, actually, interestingly, was literature. And I loved to read books. I love to read about, great people, achievements in other places. As a 15-year-old, I would write fantastic articles about women in politics around the world. I followed the careers of Indira Gandhi, people like Bandra Naike of Ceylon at 15. I think I was very well informed about what's going on around the world at 15 because the nature of the environment where I grew up was the one that encouraged scholarship, encouraged inquiry, critical thinking, seeking for knowledge. We were just hungry for knowledge, and we enjoyed it.
Were your parents strict?
Well, if you ask my son, he will say they probably were very strict, but not to us. I had very loving parents. My parents were very much interested in us being successful. Mm-hmm. That was the extent of the strictness. We had a strong, moral grounding about what is right and what is wrong. We were all encouraged to always look to how to help others who were not as privileged. I will have to say I came from a fairly privileged background because, I had everything I needed. Mm-hmm. We had a lot of things, and we were always, made aware that though we were fortunate to have those things, many people were not as fortunate. And we saw that because we had relatives who did not have as much. We had extended family people who did not have as much. But we always were brought up to understand that we have a shared humanity. We're all one. Wealth does not define you. Positions do not define you. Academic achievements do not define you. We're one shared humanity. We're as good as the next person.
Is there one or a few words of wisdom you remember from either parent or both of them that you still use to this day?
Yeah, quite a lot of them. My father will always, remind us, that his name means that, all gifts come from God. So you cannot assume that you're getting it out of the power of your own will. It is by the grace of God that whatever you have or whatever you accomplish, so that's one of the constant refrains in the house, that in everything, show gratitude, be thankful to God, because it's not just you, it is a blessing. Yeah. We were always taught to be respectful of everyone else. There was always that kind of, sharing. Whatever you have, be willing to share it with the other people. And so we had all these. It was a constant moral foundation that was being instilled in us as children, and even as adults. My father lived a long life. He passed away last year. One of his favorite things is a fool at 40 is a fool forever. So never be a fool. So we always try not to be foolish and stupid.
In May 2013, last year, you gave the opening keynote lecture at the World Congress of Nephrology in Hong Kong to thousands of physicians and from all over the world. What would you say are some successes that came out of that Congress?
Well, yeah, I think, it was quite an honor to be invited to do the opening day keynote lecture, because one of the things we've always tried to say is that the global problems, and then let's talk about healthcare for a minute.
Yes.
Solving the problem with healthcare is not just about science. Science is important, but if you cannot translate the findings from science to the reach of the wider population, then something is wrong, right? So if we take cardiovascular diseases, for example, we know that about 32 million people will have heart attack or stroke every year, and we have 17 million people will die globally because of cardiovascular diseases. But most people will think that all of these deaths and devastation are occurring in the West. It is not. 85% of the global disease burden for cardiovascular diseases occur in the developing countries of the world. And yet 85% of the resources are in the developed countries of the world. So flip it. What you see is that 85% of the resources are devoted to taking care of 15%. And 15% of the resources are available for 85%. Now, if you take the science that we're talking about, much of the developing world do not have any benefit from the scientific discoveries that are coming because the foundations are weak, the infrastructure is weak, health literacy is non-existent. Until we recognize that beyond science, there is more we have to do to bring the benefit of science to others, then we're going to be missing out on a whole lot of people. That was the subject of my discussion in Hong Kong. My lecture was talking about what we need to do beyond science to get this, and that is in terms of education, knowledge dispersion, in terms of infrastructure and economic improvement. All of those things are important in bringing the benefits of science to the people.
Now that you mentioned that, I want to talk a little bit about the Heart Institute, HIC, the Heart Institute of the Caribbean, which you founded about 10 years ago in Kingston, Jamaica, is now the premier center of excellence for cardiovascular care in the English-speaking Caribbean. What were conditions like when you got there, and what conditions in particular improved remarkably over time?
Thank you. A very excellent question. One of the motivations for starting the Heart Institute of the Caribbean was, again, to demonstrate in a tangible way that these problems can be solved, but you have to be committed to solving the problems, and you have to think out of the box. You can't, I think there's an old saying I've seen that, the mindset that created the problem cannot be the mindset that will bring a solution. If you want to solve a problem, you have to come with a different mindset. So several years ago, we came on a visit to Jamaica, and while visiting Jamaica, we had somebody that needed cardiovascular attention. Then usually we know as cardiologists that if you have a cardiovascular problem, time is critical. Time between life and death can be seconds. Unfortunately, this individual was trying to get an appointment to see a cardiologist. The cavalier attitude that we saw was totally unacceptable, telling the individual they have to come back, make an appointment for 3 months to get a consultation. I said, okay, why don't you get an echocardiogram or stress test? It's another 3-month wait. Now, in 3 months, if you're actually having a cardiovascular problem, that individual could be dead. So we saw that there was a big problem, and that was very surprising to us, given the proximity of Jamaica to the United States and the amount of influence the United States has on Jamaica, and the number of Jamaicans that have been very successful in the United States. Now, the other thing we thought was very odd was much of the well-to-do had already come to the acceptance that the way to get their cardiovascular care is to get on the plane and fly to Miami. Now, 2 problems here. If you actually do have an urgent cardiovascular situation, you cannot get to Miami. Even if you have your own plane in your driveway, you will be dead before you get to Miami. That's number one. The second one is that we saw something that was so odd. We saw repatriation of wealth from a poor country to a rich country in search of health care. And we thought that didn't make any sense because that had to be the other way around. And that's why we decided to start on this journey. Now, when we set up the Heart Institute of the Caribbean, some of the key things that happened is that immediately the landscape for health care changed in Jamaica. It encouraged people in other areas of medicine to see that you could do things differently. What the colonial masters had bequeathed on the colonies had been essentially an outpatient department that focused mainly on prescription medicine. But that was 100 years ago. We have learned a lot over time that it is not prescriptions that help to cure everything. We know that diagnostics is very essential. We have an advancement in technology that has led to making better diagnosis, effecting better treatment strategies, saving money actually. So to continue to practice a polyclinic model where people line up and get prescription, it's not the ideal way to practice medicine. And when we established the institute, we showed that you can create a cardiovascular center of excellence where you can begin from the comprehensive diagnostic testing to therapeutic interventions. And it's been very well received by the people, and I think we've made some difference.
How would you say has HIC positively impacted the Jamaican economy to date? And how does the clinic approach sustainability and avoid obsolescence?
Well, excellent. Because part of the challenges you're going to face is when you start doing something like this, then you begin to look into capital formation. How do you, marshal enough capital to set up an institute that can deliver these services? Well, the common thinking, the traditional thinking to third world is that it has to be charity. If it is not charity, most of the routine people, most of the traditional sources of funding are not interested. The problem is that charity is not sustainable in the long term. What is sustainable is to creating a socially conscious investment vehicle that recognizes that there is no equity in income distribution. And so you have to come with a creative way to make sure that no one is turned away just because of inability to pay. And what we have done at the Heart Institute is to create a tiered pricing structure where those who can afford to pay the full price, which by the way is still only about 10 to 20% of what they're flying over to Miami to pay, those individuals can pay the full price. And then those individuals who are fully indigent can pay little or nothing. And we do a lot of patients who are fully indigent that cannot pay anything. Now, the problem is that you have to manage this very carefully, because you will also have individuals who will have the ability to pay but do not want to pay. Because for one, they have been fed a daily dose of charity that everything has to be funded from somewhere. Those individuals, fortunately, are not in the majority, but they are there. They're quite significant. So you have to manage that. The key thing is once you have a program in place and you have policies, you have a means test, and you train your staff well so that you are not, it's not a top-heavy decision-making process. I have billing clerks that can assess individuals and determine their ability or inability to pay, and will assign them the appropriate category. And that has worked quite well. Now, you also choose your equipment very carefully, because you want to use equipment that can withstand the power fluctuation situations in developing countries. Most of our equipment, we have to pick multimodality units that can do more than one thing. It comes from our understanding of the medical equipment side of what we do. We also have to recognize that the latency in power distribution, the power fluctuation, the voltage regulation issues, and so we bring engineers in to work with us to create voltage suppression units that will make sure that our equipment is protected, because that is one thing that can drive you out of business fairly quickly. You bring in an equipment and within 2 days, it is gone because of power fluctuation issues. So these are the things that we understand and we deal with them. The point of the matter is that they can be dealt with. You have to understand what the issues are. But what is not acceptable is to resign yourself to what somebody else has said, that because you have these fundamental problems, you should not aspire to give to your people what modern medicine can afford.
You know, as you mentioned that, I'm thinking you venturing into the Caribbean, coming from Nigeria, studying United States and so on. There's a different mindset, and you mentioned the legacy of colonialism, and I wonder what were some of your what was your greatest challenge in setting up this clinic, but not only that, in dealing or helping to transform the mindset so that it can work, there can be some synergy between your employees and the clinic.
Well, it's like I said, this is a journey that we got into with our eyes wide open.
Mm-hmm.
We did not expect that it will be easy. If it was, it would have been done, right? Now, here is the problem, and I will say that this is probably not just a problem of Jamaica. It is a problem of the developing world, right? I talked about courage. First of all, having the courage to make a difference, then you can practice the other virtues. Now, I will dare say that you can modify that to say courage without confidence is not going to lead you anywhere. Courage without belief is not going to lead you anywhere. One of the things we're lacking in the developing world, and I think it's from years of colonialism and mental enslavement, is that many of our people just do not believe that we can. So we have this mental block that tells us that we're not capable of doing it. I will tell you that somebody, a very important person, said to me when we had a meeting to see if we can get some support for this, his whole mindset was to see if I can use my influence to get Cleveland Clinic to come and build a facility in Jamaica. My retort was very terse and direct. I said to him, it is called Cleveland Clinic for one reason, because the people of Cleveland built it, and that is in Cleveland. We should be talking about building Kingston Clinic, and we don't need the people of Cleveland to come and do it. So it's overcoming that mindset. And that mindset is so pervasive that you will find it at the lower level, at the mid-level, at the highest level. And so even when you're talking with people, when we built the Heart Institute, in all my meetings, years later, some people that could have been helpful to us confided in me that they never believed it was possible. And these were people you will look at and think they should know better. And that is the problem, is the mental enslavement, the colonial mindset that we find in many developing societies. That is one of the biggest obstacles to development that we see. That's number one. The next one is because of the same mental enslavement, the worldview is clouded about who is capable and who is not capable. If you look a certain way, in their mind, you couldn't get it done. They're looking for somebody who looked a certain way because that is the way their mind has been warped over time. But it is changing. There are a lot of young people that are rejecting those, stereotypes that we can help ourselves. We don't need saviors from elsewhere to come and save us. We can save ourselves. Hey, we are saving people all over the world. If you look around the United States, you're going to see Jamaicans doing fantastic, great things.
Yes.
If you look around Europe, you're going to see Jamaicans, you see Nigerians doing great things. Why is it then that when you come inside Jamaica or Nigeria or Ghana, then somehow the same people who are doing great things all over the world are convinced that they're not capable of great accomplishments? And that is what we reject, and that is what we're trying to change.
I feel almost foolish to ask you if you ever had any doubts, but I'm only asking you this because part of my audience are other doctors, and I really believe in this concept, and I believe that you're doing a great job selling it. But I want to ask you this question. If we were to take the position that we do not choose ideas, ideas choose us.
Right.
Can you explain why you, Dr. Madu, what do you have, and what is it in your character and personality that such an innovative but demanding idea would choose you?
Some people who, I guess I would say I'm persistent. right? I have convictions, and I'm confident, and I have courage. I believe that I can do what I set out to do. Now, those who are less charitable will say I'm very stubborn, right? And in this case, I think that stubbornness, I will wear it as a badge of honor. We have no doubt that we can change things because we understand the way you can take technology. Now, let me tell you something, right? One of the things I encounter that I said to people, we're not ready for this. That is the kind of thing, or this kind of technology can't work here because that is too advanced. My comment was, it is like telling somebody that you cannot use email because we're in Jamaica. We just have to stick to telegrams and writing letters. The world is changing, and we have to embrace that change. The way you embrace the change is to recognize advances in science and technology, and then find how you can innovate those advances to solve existing problems and solve emerging problems. The work we're doing, the technology to do the work we're doing has been existent in the West for so long. But there are also people who have gotten comfortable with the life that is good, and there's a lot of wastage taking place because nobody has been challenged to innovate and make a difference. And that is where we use technology, for example, to break down barriers so that you can improve access to care across nations, access to care across communities. And this is one of the things I'm going to be speaking about later in the year when I'll be speaking in Singapore, the National Development Summit for Singapore. Now, to think that we have people in advanced societies looking at what we're doing, saying, come to us and help us understand how we can do better. And yet, in our own societies, we have self-doubts. I was in the United Kingdom in April, speaking to an international audience. We had about 4,300 people attending. And in my lecture again was talking about how you use technology to break down barriers and extend care to rural communities. This can be done. We're already doing it. We have telecardiologists scattered all over the world contributing to the care of patients in the Caribbean. These patients are not paying 1 cent more for that. But these are specialists that they could not afford to ever have the opportunity to see. But we have used technology to break down barriers so they can use telemedicine to see those patients, take care of those patients, provide quality assurance to what we're doing. And yet, we don't have confidence in ourselves. One of the things we're hoping is that we're going to shatter all of those kind of thought processes to say we have to believe because we're capable. If we believe because we're capable, then we'll have the courage and we have the passion to drive our vision through.
What was the reaction like when you first proposed this concept to other physicians? And what about the government of Jamaica and Nigeria?
I say it's an ongoing process. Mm-hmm. I say one of the things is that when people have these preconceived notions that are formed over time, it is, change is a very frightening concept.
Yes.
When you propose something that looks like it's too radical, it changes the way things are done. People get afraid because you're going to take them out of their comfort zone. And you're going to see several reactions. And those were the reactions we saw. You're going to see individuals who are excited because they never knew they will ever witness this kind of change. They will embrace you, but they don't have much to do to help you along, but they will give you moral support, which is good. Mm-hmm. You're going to have individuals who just don't want anything to change because the status quo has been good for them. They have been comfortable in that life for so long. They're neutral, but they don't want any change. Then there are people who feel so frightened and so threatened. Those are the most dangerous elements. And they will go out of their way to block that change. even if that change will save their lives. They will become so blinded by trying to defend, in quote, their way of life. They do not want that change because it will disrupt the natural order of things. Those are the most dangerous elements. They will go to every length to try to block you. And we're still dealing with them. They don't disappear. They will go quiet for a minute, but they are the ones who are going to be singing to the authorities that these things are not needed in Nigeria or Jamaica or Ghana or wherever. They are the ones that will sing to the authorities that it is better to put some fund away to send people to India or to London or to Germany or to US for treatment. These individuals are there and do not ever think that they're going away, and they can't help themselves. They believe they have as much passion as we have, but I'm sorry to say their passion is misdirected because they're impeding development process.
Let me go to the chat room for a second. Patrick said, good evening to you and your guests. Is there a link or commonality between diabetes, hypertension, and heart disease?
Yes, that is very well understood now. Diabetes and hypertension. The question was diabetes and hypertension, right?
Yes, diabetes and hypertension.
Yeah, diabetes and hypertension are two of the strongest promoters of cardiovascular disease. And diabetes again and hypertension are also linked to overweight and obesity epidemic. So that's a global trend. And then let me talk about diabetes for a minute. Right now, it is estimated that we have probably about 1 billion people around the world that are overweight or obese. Many of those individuals are at risk for developing diabetes. The projection is that by 2025, we're going to have maybe 350 million diabetics around the world. Now, the frightening statistics is that 70% of those diabetics will be in developing countries of the world. What does that mean? Diabetes is a very strong risk factor for cardiovascular disease. In fact, in cardiology, we now recognize diabetes as heart disease equivalent. So if you have diabetes, it is very likely that you have coronary artery disease developing in one stage or another. Now, when we're talking about 350 million diabetics around the world and 70% of those are in developing countries, then you can see what epidemic of cardiovascular disease we're looking at in the next several years to come. If we take Jamaica, for example, that data is about maybe 1 in 5 or 1 in 6 people, adults, have diabetes. Now, we're seeing more diabetes in young people as well. Among overweight teenagers, you have about 20% of them developing type 2 diabetes, which is not something that we have seen in the past. So if you take that and then see that in Jamaica again, you have about 20 to 30% of people have hypertension. So you have 25% of people with diabetes, 20 to 30% with hypertension, adult population, and then you have about 4 out of 10 men that are overweight or obese and 6 out of 10 women that are overweight or obese, then you can see the perfect storm for cardiovascular epidemic. And we're seeing it. Now, we don't have the capacity in Jamaica still to deal with the extent of the problem because we don't have the capacity in terms of human capital, in terms of resource capital, resource allocation. Then we have to find creative and innovative ways to deal with this problem. Those creative and innovative ways have been what we have been pioneering at the Heart Institute of the Caribbean. We're doing a lot of community programs to get word out to the community. We're doing a lot of things to bring early screening in place. We're starting a chest pain service, and we're starting a 24-hour emergency hotline that will allow people to come in at any time in a 24-hour period of time with active problems, and our interventional cardiologists will address the problem because that is what saves lives.
And Patrick, again, you were right. Colonialism bred insecurity and dividends. And Sydney asked, what do you think made you so confident and so forward thinking?
I don't know. I'll say God.
If you had the ears of all the heads of CARICOM for 1 minute, and what if they ask you, can it be done? Can it be sustained? And what would you want them to know about what you're doing in Jamaica and Nigeria?
Well, my answer to them will be to say, can it be done? Yes. How do I know? Because we have done it. The next one, can it be sustained? Yes, it can be sustained. We've done it. It's 10 years, and we are sustainable.
What do you say to those who refuse to acknowledge the advantages of technology and that it is here to stay?
Well, I think, for those who refuse to acknowledge the advantages of technology, I will hope that it is just ignorance, that when they're properly educated, then they will understand. I'll give you a few simple examples. So we are talking now. You are 1,000 miles away. I'm in a different location, and we're having this conversation, and it is streaming, and people from different parts of the world could go in and listen to the conversation and be part of the conversation. That is technology making a difference. We couldn't do this 30 years ago. Do we say then that this is not useful? Information is moving at the speed of light. All the young children that are in their teenage years now, they communicate with their friends all over the world. When I was a teenager, we used to write letters. You write a letter and take it to the post office and then wait for 2 weeks for the letter to get there and then wait for another 2 weeks to get a response. Sometimes you don't. Then you don't know if the letter ever got there. How do we do it now? We get on WhatsApp and send a message and we know right away. We get on BlackBerry Messenger. We do texting. We do Skype. We do all kinds of things. That is technology. Now, what we're saying is that we can also take these advances in technology and bring it to healthcare. And that is what we have done very successfully. We have our own portal for telemedicine consultations where individuals can sit at home and dial in and select a doctor and then set up a telemedicine consultation. Some of these individuals are not able to get out of home. Cell phones have been in use for many, many years. Now, what cell phones have been used to do in Africa has been different from what is used to do in the West. We have millions of people that are not banked at all. Now, M-Pesa in Kenya turned it around, and all of these people can use the cell phone to transfer money, mobile money movement. That is use of technology. Now, there are some countries where individuals that are opposed to technology are still convincing their leaders and their government that they do not need to embrace technology. And those countries are going to lag far behind. If you are not moving forward, you're going backwards. If you're standing still, you're moving backwards because the rest of the world is going to be moving and you're going to be caught standing still.
Romeo asked, how do you know who is the right match for your team? And how do you get them to work as one unit to carry out your passion?
That's a very, very good question. In the beginning, we were looking for people who were smart and could be trained in one thing or another. And we made some mistakes, some false starts, but we learned. Now, what do we look for now? What we look for now is passion, commitment, and loyalty. Those are the three things that matter the most. The number of degrees you have don't mean anything to us. We don't care, because if you have commitment, you will have dedication. If you're loyal, you will be loyal to the cause. If you're passionate, you're going to put your effort into learning it. And I will tell you that after some missteps, we have a team at the Heart Institute of the Caribbean now that I tell people I think we have the best team in all of Jamaica. I don't think there is any workforce in any organization in Jamaica that beats the workforce we have at the Heart Institute of the Caribbean now. What do they have in common? Is commitment and passion. Our team is so dedicated to our goal. They're so passionate about what we're doing that it's not passion, it's not something you can teach somebody. It's an internally driven thing. It comes from within. It's either you have it or you don't have it. If you don't believe, then you're looking for a paycheck. Then when the wind is rough, you're looking for an exit. Fortunately for us, we learned that what is most important is to find individuals who are loyal, committed, and passionate. And that is what our focus is. Once they have it, we believe the rest of the things we can mold.
Dr. Madu, what procedures are you capable of doing in the clinic, and are there procedures that you are not able to do that you must refer to a different hospital or doctor, depending on the patient's situation?
Right. That's what we do. We've set up the facility in a way that we can begin with a complete consultative service to the non-invasive diagnostics, to invasive diagnostic work, and to the invasive interventions. Now, just to make it clear what I say to people, because this question is a very important one. It hinges on one of the things that keep people from moving forward. Like, one of the challenges we had coming is some people will ask questions, but are you going to be able to do this? I say, no, we can't do that yet. He said, well, why don't we wait until we can do everything? Even within the United States, you will be surprised to learn that even the best hospitals in the United States do not do everything. There is always one thing that you will not have the ability to do. Now, for us, that fortunately, 95% of the things that are needed to take care of a cardiovascular patient, we can do. Now, there are a few things we're still not able to do, and those things we will have to find a way to get the patients to where they can be done. There are some things that probably in the foreseeable future we may still not be able to do because of logistical problems. Let's talk about heart transplant, all right? We cannot do heart transplant because to do heart transplant, you have to have an organ registry. You have to have a way of transporting, harvesting the organs, moving them. And when we're talking about cardiac transplant, it's one organ. An individual has to be dead, and that organ has to be harvested within a short period of time and then transported by helicopter or air ambulance within a short period of time. It is something now CARICOM as a unit can set up an organ procurement and delivery service. That is the only way cardiac transplant can be done in the region. Now, we do everything else. There are other procedures like radiofrequency ablation for hypertension that started out recently, but now it is kind of a little bit shaky. We are not doing that. But most of the things that are needed, we're able to do, fortunately.
With your experience and qualifications, you could have set up clinic anywhere in the world, the United States for a very high salary job at one of the major hospitals. Why focus on the Caribbean, and why especially Jamaica?
Well, we did, so we started, my career actually was built in the United States. And that's why I'm still in the United States. That's where I do, most of my thinking, from. Now, we came to Jamaica, for me, it is a social movement. Setting up the Heart Institute of the Caribbean is anchored in our tourism. We believe that we have done this thing. We're doing it in the United States. And we have been recognized for knowing what we're doing. Why is it that people continue to suffer in our own communities? Because these things are not being done. And inside a place, in the problem, you may not recognize what the opportunities to make a difference are. Sometimes you have to put on a different pair of glasses before you can see. So for those of us that have put on a different pair of glasses, and we're doing these incredible, fantastic things in the United States of America, and we see how it can be done, we saw it as an opportunity to come and make a contribution, to make a difference at home. I call Caribbean home. Caribbean, Africa, they're all home for me.
I want to take a very, very quick break because we lost so much time. But I would like you to leave you with this question before the break. Are the governments in the Caribbean aware of HIC and your vision to bring affordable healthcare to the poor communities? And if so, what kinds of collaboration do you have so far? So I'll leave that with you and I'll take a quick break.
Okay.
We are back with Dr. Ernest Madu. Dr. Madu, the question I asked before was: Are the governments in the Caribbean aware of HIC and your vision to bring affordable health care to poor communities? And if so, are there any kind of collaboration so far?
I wish the response would have been yes. We have governments across the Caribbean beating down our doorsteps to support what we're doing. On individual levels, we have had officials within governments within the region have expressed their desire to support what we're doing. We will, of course, like to see the governments within the region embrace what we're doing in a more constructive way. We will love to work with them to improve access to quality of care within the different communities within the Caribbean. We're doing this on our own for the most part. And I'll tell you some of the collaborations that we have created, to forge this, to forge relationships and force this, progress. We've created a mobile cardiac service that go out to public hospitals, to perform procedures that do not exist in these public hospitals. We finance it entirely out of our proceeds. We would like to see an expanded approach to this mobile cardiovascular, program. The way that can happen is when the governments come in and support what we're doing. It gets a little bit more complicated when your cost of doing business is very high, because most people think we'll get duty concessions for bringing in equipment and medications and so on. We don't. We pay very high duty, which is surprising to many people, because in some areas of industrial activity, like the hotel industry, I understand that they have almost 100% duty waivers. It doesn't happen in medicine. We pay a lot. That's why, again, we have to be very creative in managing our resources. We're working with the University of West Indies Hospital cardiac surgery program. We don't do cardiac surgery in the facility, but we have a streamlined process with the cardiac surgery department at the University of West Indies Hospital. We have some excellent young, physicians working at that cardiac surgery program that work closely with us. We also work with University of Pennsylvania, where some cases that cannot be done locally or where the individual wishes to go abroad, we facilitate them going to Dr. Zama at the University of Pennsylvania. And for the local program, we're working with Dr. Joseph Bligen. Dr. Bligen is a young man who is working very well with us, and we have a consultative service in cardiac surgery at the Heart Institute, where he comes and evaluates patients. We have CAT conference with our interventional cardiologists. We're hoping to expand the cardiovascular surgery program with the University of West Indies Hospital, so that these patients can have a more seamless approach to getting their cardiac surgery needs met.
In the chat room, Kim asks, what is atrial fibrillation and who is most still at risk?
Yeah, atrial fibrillation, it's okay. The way to understand it is that the way the heart works is it begins with electrical activity, and ends up with a mechanical activity, right? Take your car, you get into your car, you turn the ignition on, the lights come on, that's the electrical activity. And then you crank it up, the engine comes on, and you let go, the car moves. The heart works, the human body works the same way. So the electrical activity starts from the upper chamber of the heart and then goes down to the lower chamber, and then the heart pumps, the blood goes, and so on. So that electrical activity coming from the upper chamber of the heart is a very organized, synchronized activity. It comes from a central station that sends the impulses down and then activates the rest of the chamber. Sometimes different areas begin to act autonomously. They go on a rampage and start generating their own electrical activity. In that sense, now the organized electrical activity is lost, and we have a disorganized activity. That is what atrial fibrillation is. Now, who is at risk? Hypertension, high blood pressure is probably the number one most common cardiovascular antecedent cause of atrial fibrillation. So most people with uncontrolled hypertension will be at risk. People that have had ongoing cardiovascular problems could be at risk. People with pulmonary disease, chronic obstructive pulmonary disease, will be at risk of developing atrial fibrillation. And as we get older, that risk increases. But if we have the conditions that I have just described, then our risk for developing atrial fibrillation is increased. Now, the danger of atrial fibrillation is that as long as this rhythm, this electrical activity is disorganized, then there is a likelihood that blood clots could form, and those blood clots form could dislodge at any point, and then a stroke can occur. That is why we want to correct it.
And Kim asked again, what can an individual do in the daily life to prevent the risk of heart disease?
The basic things that we recommend is first begin by recognizing the risk factors for cardiovascular disease. Some of those risk factors can be modified, some cannot be modified. Now, the modifiable risk factors are what we focus on changing. Now, those will include high blood pressure that you can control, diabetes, you can control, exercise. The more sedentary you are, the more your risks. So we recommend exercise. Tobacco use is a risk factor. So if you're smoking, you need to stop. Incidentally, again, this is why we have to be very aggressive. Most people do not recognize that the greatest rise in tobacco use, again, is in developing countries of the world. In Africa, sub-Saharan Africa, for example, is growing at 4.3% per year, while in the rest of the world, smoking is going extinct. Now, high cholesterol is another risk problem that you need to work on. So diet is very essential. Nutrition, dietary discretion, is something that we recommend. Watch your portion size, eat the right things. The fruits and vegetables are good for you, and watch your weight. It's the more your body mass index increases, the more your risk for developing insulin resistance and diabetes, and those will put you at risk as well.
Romeo said, as Jamaicans, we eat a lot of rice. How is that related to heart disease?
Well, rice is carbohydrate, and it can make you put on a lot of weight. So if you eat a lot of rice and you don't exercise, yes, we do eat a lot of rice in Jamaica. If you eat a lot of rice and you don't exercise, you're likely going to gain weight, and your waist circumference is going to expand. That increases your risk. And like I said, if you gain weight and you increase your risk of insulin resistance and diabetes, that puts you at risk for heart disease as well.
And Patrick said, it seems counterintuitive that the developing countries have a higher incidence of cardiovascular issues. What are the reasons for this?
Well, okay, yeah, it is indeed counterintuitive. It may not be that they have a higher prevalence, so to say. What it is that the outcomes are more devastating. The disease burden is higher because you go into a lot of things. Health literacy is one. For those of us who live in the United States, we know that calorie counting is routine for most people. People go into a grocery shop and they spend all the time looking to see what the content is. We're not that health literate in developing countries yet. Exercise is a common thing. Look at the number of exercise facilities all over the United States. People are buying up gym memberships. They're very conscious of their exercise level. That's why the wearables that have come in, the Fitbit and all of these things, are getting a lot of rave reviews. We are not there yet in developing countries. Disease surveillance in terms of looking at risk factors and catching them and treating them. We're not doing that. Hypertension, for example. In Africa, for example, most people do not know that only 20% of people that have hypertension have been told that they have hypertension. And of all the people that have hypertension, less than 10% are treated to goal, right? Are treated at all to any sufficient level of control. And if you're looking at people who are treated to target, in many communities in Africa, it's less than 1%. And so if you have less than 1% of hypertensives in certain communities treated to target, then you can see that the risk burden is going to be very high. The risk of cardiovascular, the disease burden for cardiovascular disease and stroke in sub-Saharan Africa is 5 times the disease burden in Western countries. And then if you can treat hypertension to goal in Africa, for example, you can save 250,000 lives a year. So we have a lot of fundamental issues. And now this is in the area of individual control. Then we talk about institutional issues where the infrastructure is weak. We do not have facilities where people can actually go and get well taken care of. We do not have facilities for intervention. And that is why the work we're doing is extremely important. And because these things have not existed for many years, people do not see the need for what we're doing. But what we try to highlight to them is that the epidemic of cardiovascular disease is going to be a lot more devastating than anything else they have encountered, because the infrastructure is simply not there, and people are affected at their most productive years of life. And when they succumb to cardiovascular disease, it devastates families and it devastates national economies.
Raphael said, I understand that the lowest national incidence of hypertension is found in Nigeria, and the highest is Germany. This should imply lower incidence of heart disease. Is this correct?
Well, that's actually not correct. Because when you look at the statistics in Nigeria now, hypertension is rising. Because when we talk about westernization of indigenous cultures, people are no longer living in rural areas and going to the farm and exercising as it were all day long. People are moving to the big cities. They're driving through drive-thrus and going to, fast food restaurants. The mark of affluence is now to sit in your air-conditioned car and order as much burger as you can. Now, that is leading to a rise. We have 2 cardiac centers and we have built in Nigeria, and we're seeing a dramatic increase in cardiovascular diseases in the country.
Why should the medical community pay attention or adopt the concept of early intervention?
Well, what I have said is that prevention is the most cost-effective strategy, especially in societies where the resources are minimal or non-existent. Because if you have a heart attack or stroke, the cost of treatment is very high, the cost of rehabilitation is very high, the cost of ongoing treatment is very high, but the cost of prevention is very low. And there are community initiatives that can help in forcing the issue of prevention. One of the easiest things that people can do is walk. There is no cost associated with going to the local parks and then walking or jogging or running, especially if you're able to do so. But we also recommend to individuals who have been inactive for so long that before they embark on any aggressive exercise routine, to check with their doctors to make sure it is safe for them to do so.
Dr. Madu, I don't want to take advantage of your time and abuse this new relationship, but may we have 10 more minutes of your time, seeing that we started so late?
No, no problem.
Okay, thank you, sir. What recent advancements in cardiac medicine are you adapting in your treatment of patients?
Okay, let me paraphrase it to say what we're trying to do is to try to bring the reach of science to the people, to make sure that advances that have been recognized elsewhere, have been validated, are readily available and accessible. So let's begin with the way we're using technology, to make this thing happen. One of the challenges you face in low resource economies is to get the right set of expertise into the community, because the cost of getting that expertise into the community is very high, and you're competing for those experts with more established societies where you cannot afford to pay them what those other people will pay them, and you cannot afford to create the infrastructure in the national society that they're used to elsewhere. They're not likely going to pack up and move to Jamaica. They're not likely going to pack up and move to Nigeria. They're not going to pack up and move to Ghana. So what do? We use technology to break down that barrier and make it easier for them to stay where they are and provide services in Jamaica or Nigeria or Ghana. How we do that is by looking at what the skill sets are. What we do in cardiology requires a lot of diagnostics. It is easy for me to take young college graduates and bring them into my lab in Jamaica and then give them 1 year of solid training in diagnostic imaging. I teach them how to do echocardiography, which is ultrasound exam of the heart. I teach them how to do stress testing. I teach them how to do Holter monitoring. Now, the next thing I do is I build a strong technology platform with a lot of smart people that know how to manage technology. And then we use these individuals that we have trained to do the diagnostic studies, and then we collect the information, we dump it on our server, and then send it to a cloud server, and then the guy in the United States or Germany or Britain or Canada can sit in the comfort of his location at Mayo Clinic or Vanderbilt University or wherever and log into the system, review this diagnostic data, and provide expert opinion. This is the way medicine is practiced. So when we do that, we're taking advantage of the intellectual capital that we cannot locate in Jamaica to provide services to patients in Jamaica or Nigeria or elsewhere. These are also individuals who are very much in tune with the latest advances in cardiovascular medicine. Mm-hmm. And because they are in tune with the latest advances in cardiovascular medicine, they can translate same to the patients we take care of. Once we know that that can be done, it encourages us to acquire technologies that embrace these latest advances in technology. A case in point is that we have a freestanding cath lab, for example, where we can do primary intervention for patients having heart attack. We're launching our mobile heart service, emergency ambulance service that's dedicated to heart care only. We're doing a 24-hour service to allow patients to come in and get care. Guess what? When the patients come into the lab and they do the angiogram, then I have the advantage of having experts from all over the world that can log into the system and look at that image and advise the interventional cardiologists on the ground that this is the best approach. Maybe this is one that will require intervention with placement of a stent, or maybe this is the one that we will need to get our friendly surgeon at the cardiac surgery program to come and take a look and take the patient to surgery. But it's about collaboration, taking advantage of the expertise that we can amass from all over the world using advances in technology.
For some doctors who might be looking at this program tonight, listening to you, who are thinking about participating, how do they go about being part of this program?
Easy. Send me an email, emadu@caribbeanheart.com. We are very eager to collaborate with anyone who share the same passion and the same commitment and is going to be loyal to the program. That is the number one requirement. That's the only requirement. If you have something to contribute and you want to join us, just shoot me an email. We're constantly looking for training opportunities for our staff. We're partnering with St. Jude Medical in the United States now. We're going to be sending 2 young people to the United States for training as pacemaker technologists. That has never happened in the Caribbean. So these individuals will now come home and support pacemaker implantation technology in the region. That is one of the things we try to do well by building people. The way we build people is to give them skill sets that will serve the community. And that way we build internal capacity and we keep this program going. I want this thing to keep on going years after I'm gone.
Dr. Madu, with all your experiences, all your lectures, and all your journals that you've written, what still surprises you in the field of cardiology? And also, what still surprises you about yourself in cardiology?
Well, the surprise in cardiology is that, the discoveries never seem to stop. There is always something new coming down the pike. There is always an improvement in the way we do things. So in a way, you think we've reached a limit. There are hundreds of cardiology journals. Researchers are publishing things, but almost on a daily basis, we are finding new discoveries that improve the way we do things. Now, about myself, I'm not sure that I know exactly what surprises me, except that some people think I should be tired already, but I think I'm just warming up.
I like that. I really do like that. We need lights like you in the Caribbean and Africa. So please don't get tired. Do you have any regrets or unfulfilled dreams now?
No, not at all. I just the only regret I have, it's not a personal regret. The regret I have is that I was hoping that by now the mental colonization of my people would have receded. It hasn't. They're still mentally enslaved. That is my only regret.
Wow, that's powerful. What is one thing about you most people do not know that would surprise them?
I think what will surprise them is, actually I do sleep. One of my colleagues is of telling people that I never sleep. That's not true. I actually do sleep. But
sorry.
I think many people will be, surprised that I do enjoy a quiet time with my son. Mm-hmm. I like to sometimes just, play around with him.
Yes.
And not, some people who think they know me think that all my time is consumed with serious matters. But I like some levity, as we say in Jamaica.
Looking back, what would you change, if anything, about your education, way of doing business? Would you change anything?
Yes. What I'll change is I wish that, I'm very grateful for coming to the United States of America. I wish I had I wish my eyes opened to what was possible to the extent. I guess when I was younger in Nigeria, I always knew a lot of things were possible. I always knew that we could make a lot of difference. But coming to the United States showed me how a society can organize itself in such a way that individuals who may be ordinary people are never afraid of standing up for something and forcing a difference. What America taught me is that the group think is not always the way to go. You can break out of the group and do what people think is impossible, but just believe in yourself and believe that it is possible and you get it done. And there are many stories like that all over America. I want to see more stories like that across the Caribbean and Africa.
When are you most happy?
Say what?
When are you most happy?
When I'm at home.
What is gratifying about being Dr. Ernest Madu?
Just I love the fact that I have the determination and the persistence to stay the course in what I believe in. If I believe in something, I will see it through to the end. So that's what I like about myself. I am not afraid of taking on a challenge because I have the confidence that I will overcome that challenge. And that's what has helped our mission. Because, like I said before, there were people who were out to make sure that this heart center business you're talking about don't happen in this place. And those people are still there. But the message that I always send to them is you're messing with the wrong person, because we're not going anywhere. We are going to do bigger and better things because that's the right thing to do. As long as I know that what we're doing is making a difference in the lives of people.
Yes.
As considered as it might sound, I really think that this is a calling from God. I don't have to be a pastor. This is my pastoral mission. And I do not believe that any human being can stop me. Only God can say, don't do this. But now I'm hearing the voice of God saying, be part of solving this problem in Africa and the Caribbean. And I'm listening. And I'm obedient to that word. And we will keep on going.
I'm almost tempted to end the show on that note because it is so powerful and riveting and encouraging. But God is also saying, ask you just a few more questions. So please be a little patient with me. What are you most proud of, Dr. Madu?
Interestingly, I'm most proud of my son.
Amen.
My son, again, is somebody who overcame significant challenges in his young life. And to watch him, the way he is now, blossoming and being a very fine young man, that is what I'm most proud of.
Well, finish the sentence. I look forward to Sunday evenings too.
To do father and son things.
Oh.
Let me tell you one of the things, I am trying to get to Brazil with my son to watch the World Cup, right? And with just the whole idea of trying to figure out which game we're going to see, or does he want to go, he doesn't want to go, or he's excited about going. To me, that is the greatest joy ever, to think that I'm going to be able to disappear with him for a few days, just me and him, going to watch soccer.
Oh, gosh.
That is what I'm looking forward to.
This is beautiful. What are you most thankful for?
I'm most thankful, for the family, that I was born into, to the family that I have inherited, I've grown into, the support that I've gotten from my family, and that has been invaluable. So that is the thing I'm most thankful for. And I'm most thankful also for the gift that God has given me, to be able to do things that actually can impact the lives of thousands of people. And to see that what we have done have been recognized by people all over the world and being asked to come to different places in the world, different parts of the world, to help them to do the same thing, to impact yet several other thousands of people. That is something that I'm very grateful for.
Raphael said, what is the state of implementation of digital medical records in Jamaica, Nigeria, and Ghana, do you think that this is important to pursue now?
Electronic medical records.
Implementation of digital medical records, yes.
Absolutely. I think that's the way we implemented electronic medical records in Jamaica nearly 10 years ago from the time we started. At the time, it was only about 18% of practices in the United States had digital medical records. Now, what is so important to know is that it saves lives because it minimizes medical errors. When you document, then everyone else who is taking care of the patient has access to what you have documented. It's clear and legible. Remember in the days past, one of the things they used to say, doctor's handwriting, you can't read it, as if it's a badge of honor. If you can't read it, then you're prone to errors. Now, with digital medical records, those records are portable. If you're seeing a patient in Ghana, you can look at the medical records from Jamaica by just going online. It's on the cloud. Our facilities in Nigeria have digital medical records. We have a patient from Nigeria, actually, as I'm speaking to you, who was seen at our facility in Nigeria, had some things done, and was transferred to the Jamaican facility to complete his assessment and treatment. And all those records are online digitally, and they are safe because they are secured by encrypted passwords. Only those who are taking care of the patients have access to these records. And these things also now have inbuilt neural intelligence that when you do certain things, it will prompt you with questions. Say, okay, this patient has heart failure. Is he on this medication? Doctors do forget things. When the digital record asks you, as you're documenting your note, why this patient is not on this, it forces you to think about what you're doing. I think it's critical. It is timely, it is available, it is possible, it is actually not complicated.
That's amazing. That is truly amazing.
Can talk to me, I will help them get it done.
Doctor, if you could go back in time, what would you tell that 16-year-old boy?
Stay true to your vision. Do not let anybody tell you that you cannot do it. If you believe, do not let anyone convince you otherwise. Just stay focused, stay passionate, pursue your passion. That is what is going to make you great.
And the question I ask every guest, what makes you laugh out loud?
Makes you laugh out loud. Come on, you stop me with that one. You know what? Let me tell you, satire makes me laugh out loud. One of my favorite things is the Borowitz report from New Yorker. When I read that, I find myself laughing out loud.
Dr. Madu, I thank you so much for your time. I thank you for your patience. You're such a man of technology that you understood, and I appreciate your grace. I appreciate your kindness.
And again, this is what we're talking about. Persistence.
Yes.
You get it done. Technology does work. You have to believe that it will work. You have to stay committed to it. Ultimately, you'll figure it out.
It's just amazing. It's interesting that all the setting up was done and everything was so perfect. And then the creator stepped in to show us who is boss. Or so you have set it up. Well, I'm going to demonstrate to you the importance of commitment and persistence and dedication. Exactly. Dr. Madu, I would love to invite you to come back on again. I think time cheated us, but I believe in faith. I believe in the flow. So I believe everything was perfect. But thank you so much and keep up the good work. I will do whatever I can to encourage others to contact you and to participate in this very innovative initiative that you have started here in the Caribbean and Africa. Thank you so much, sir.
Thank you so much.
All right, good night.
Good night. Bye-bye.
Bye.